I'm here to introduce Dr. Tom Simopoulos, who our careers have basically paralleled each other. Brigham and Women's for anesthesia and pain, and then you're at the BI. He's an associate professor at Harvard Medical School, and his specialty is implantation, mostly electrical neuromodulation, and I think that we complement each other as mine is towards chemical neuromodulation. But Tom is a great friend, a wonderful colleague, and a great teacher and doctor. So here he is telling you about spinal pain.
Thank you so much, Sanjeet. I'll kind of move it along because I think we've already fallen behind time. But anyway, I think what we're going to segue now into kind of spinal pain this afternoon, or late this morning and this afternoon. So these next two sessions are about kind of go a little into pathophysiology, then we'll move into imaging, then we'll move into treatment, so you can get up to date with all of these matters. But anyway, as I'm asked to talk about a symptom, that's what I'm going to talk about, and then we'll slowly break it into structures, then we'll go into kind of diagnostic techniques, kind of end it where we're all going to head, and that is if you live long enough to spinal stenosis, as the spine loses its structure and moves much into a narrowed state because you've outlived the time period you were intended to live for the past, 10,000 years, because we mess with nature all the time. And then we'll conclude. So low back pain has a highly variable range in terms of incidence, in terms of prevalence, and then in terms of point prevalence at a year. And the reason is this, the way it's defined in the literature, usually between just below the T12 rib to just about the buttock crease. There's variations in that definition. There's variations also in terms of the intensity. Are we talking about life-limiting low back pain? Are we talking about just, I just got a little backache, but I'm able to function? So all of these quirks about back pain create this variation. But to give you an idea, it's in general about half the incidence of neck pain. So if we look at cervical radicular pain and axial neck pain, just about half that of back pain. So we do see back pain a lot more prevalent, and it's a problem that continues to plague us and grow. Now, if you do get life-limiting back pain, that implies that your structures are sort of not in good shape, correct? So it is highly probable that you will get back pain again, particularly if it persists beyond 24 hours. And chronic in recurrence is usually the nature of most back pain, and many people modify their lifestyles. And if we look at within a year, depending upon how you define remission, if you define complete remission, that is, I go back to normal, probably half the patients go back to doing everything they ever did. A lot of them have modification, have some pain, and therefore, that's about half, but 90% would not likely go back to the usual activities they used to do. So again, here's that 24-hour mark. I think is very, very important because that argues towards the severity and problems with structures in the back. You can see the recurrence is quite frequent. Half of them recur within the year. If you're an injured worker, some estimate up to a third, some a quarter. And then the key point is that when you see patients with this back pain, I often hope it improves within 2 weeks. That's usually the median improvement within the first 3 months. Most patients cluster around 2 weeks. Once it starts to move beyond 2 weeks, the next median where you see the blip in improvement is about 4 months. So that is why you see a lot of delays from insurance to cover things, because they kind of know this epidemiology and they're not so keen on you doing, or me for that instance, doing things to people. Although the patients are in there with their lives turned upside down, insurance is looking at this and saying, hey, you're going to just improve. We just need to deny you long enough, and then chances are you'll improve to the degree where you don't need imaging, so on and so forth. Now, if we look at risk factors, they're not just broken into structure. So I have things structure like genetics of collagen up there, but they're really then broken into, first thing is to age. If you really look at age, there are the young people that end up with early degenerative disc pain. That's usually manifested by the third decade of life. And then another spike after 60s, which is usually you're moving more towards stenosis. So you've been fortunate where many people degenerate asymptomatically. That would be like myself. And then someday you get some pain or in the back and leg because you've progressed towards stenosis without you even knowing it. Now, looking at other factors, then break into psychosocial that are really, really important. So, for instance, educational status, the ability to read, understand, and become healthcare literate is a problem. Anytime you have pain on psychiatric conditions such as anxiety, depression, there's always magnification of pain, and you see a lot of behavioral therapy starting to spike up these days that had unfortunately been put by the wayside for the past 20-something years as we move more into the biological aspect of the psychosocial aspect of the pain models that we use in chronic pain. Sorry, I went back. Looking at smoking, it is something that fortunately has been on the decline because it does increase to more spinal pain, prevalence, chronicity, and intensity of pain. Manual workers on the whole will complain more of pain because there's more wear and tear. However, sedentary workers, due to weakening of structures just by sitting around, also have an increased incidence of back pain. And this is a great book, if you get around to it, by Bogduck, which he published years ago. And I enjoyed this figure because it kind of shows you on the far right what happens when you suddenly are very active lifting and suddenly picking up something structurally very heavy or falling. There's risk of damage. Conversely, if you don't do anything at all, there's disuse atrophy, increased risk of injury. So realistically, it argues towards some moderate level of exercise or strengthening is always appropriate for the back. In other words, especially as we age, because once you get to age-related injuries, then they're harder to recover as we get older, and then you're down to doing nothing, and you quickly shift into deconditioning and go back to this left side of the graph. And this slide kind of puts it together. It puts together genetic effects. It puts together psychosocial effects, it puts together environmental, it puts together your habits, and it puts together your size. All of these feed in a complex way to the way we then express low back trouble as listed here. Obviously, psychological and stress culture depends on how well we can express these. There are cultures where obviously you have to be much more stoic, so that feeds into adaptation to any kind of pain problem. So if we look at our society, we've headed towards more pain expression, as you know, and people who have lived at least several decades as adults will gladly say that people much more express or give in to pain than they did years ago. And no matter how you look at this slide, low back pain accounts, as we've already discussed, a significant amount of lost work days. But you can see what's kind of alarming is that chronic impairing low back pain has risen from 4%, say, in 1992 to more than doubled by 2006. This is despite interventions, medications, understanding. In the back pain world, we seem to be going back more towards impaired patients. If you look at Social Security disability income from any MSK disease, we're investing a lot in interventions, and we're just going the wrong way with disability. And you can see the trends are doubling here within a 30 years time span, and they double within a 20-year time span. So there's other factors that are clearly feeding into this, and it is not simply intervention. So I think some of the psychological and social factors that feed into back pain are become much more prevalent over time. So now I'm going to delve a little bit into causes and the causes that you're likely going to face, and we face certainly in clinic. So the top is kind of what I deal with in clinic. The bottom specific causes are the more obvious and less common issues, but again, issues that are easy to identify, for instance, vertebral insufficiency fractures, neoplastic infiltration, and infection are pretty given and are diagnosed easily by imaging and are reasonably, most times, easy to correlate. The things that get trickier are what we've developed over the past 30 years is identifying that bones can develop pain problems, so-called vertebrogenic pain, intervertebral discs, facet joints, sacroiliac joints, and more importantly, dorsal root ganglia or impingement of nerve roots that we'll go over. And the rest still continue to not be easy to identify or tease out. and are currently of question as to their acceptance of pain sources in the low back. So this slide, I really like this slide. It kind of summarizes overall why back pain is a complex and difficult problem, and is like cancer pain, it's a moving target, because when you're kind of a chronic low back pain patient, you're always on the move of disc degeneration and worsening arthritis in your back, and always moving towards potential involvement of the nerve root. So if you start here with intervertebral disc degeneration, you can see this blue has an asymptomatic bunch that fits in here. So this is always the trick for patients, is that they believe always the MRI will explain their pain, and that somebody just hasn't read the MRI correctly to explain their pain. If somebody eliminated MRIs tomorrow, I think I would be excited, because there's only two people that believe that MRIs explain pain, two types of people: patient and surgeon. Surgeon throws out all the ones that are non-operative, and the patients, because that is their newly found God. If you ask a neuroradiologist, say, well, we disproved that 30 years ago, where have you been? So that is the trick. I, for instance, have advanced L5-S1 disc degeneration. It was caught on an MRI that I got for other reasons. I also have a grade 1 spondylolisthesis at L5-S1. I have no pain ever. But that'll find me at some point. But the point is that unlike other things, the MRI is not the whole story. So then it moves us into understanding symptomatic discogenic pain is a little hard, and we're going to look at that. But when you start looking, there are people that degenerate in a painful way, and they develop neural inflammation, innervation of the disc that's new, a lot of chronic pain that feeds back, that sensitizes the spinal cord. They then can move into the bone and inflame the bone and cause so-called vertebrogenic pain. They can then move off, the disc can move off and activate the nerve root. As this wears down, the facet joints in the back, or abnormal tension, can even be put on the sacroiliac joint. So you can see how quickly this whole complex kind of moves together over time, and multi-sites can involve, and you can have nociceptive and neuropathic pain that can coexist and evolve over time. So by the 90s, we started to recognize that we needed to get a grip on potential structures that cause low back pain. This is one of the preliminary slides of the 90s that I overall enjoyed, is that we started to kind of grip in that facet joints started to become much more accepted as a source of low back pain, particularly as we age. Disc-related pain was found much more commonly in younger people, but overall accounts for a very high percentage of patients, especially when they're young. And it is a difficult entity to treat in many cases, because we just don't have good treatment for disc degenerative related pain. Finally, sacroiliac pain forms 15% of chronic low back pain. If we were to go back to like the 1920s, all of back pain was SI pain, and it was just a nice, easy world. You got back pain, sacroiliac pain, done. Then we'll go over a bit, but during Dr. Warfield's era, starting in the 80s, there was a lot of work to put forth that facets can become painful. That was a new thing at then, because everybody was still focused on the discs by Mixter and Barr. It wasn't the wrong focus, it was just that there were other heavily innervated structures, and we'll look at this as we move along in the lecture. This is another takeaway slide. I know it looks a little busy, it's difficult to read, but life is probabilities, like it or not, right? So, you might be afraid to fly, but you're more likely to die if you just drive out of here than taking a plane. Same thing's true about back pain. You got to get into the probabilistic model. That's very different than medical school, which is absolute, axiomatic A equals B, for instance, or B equals A, therefore, or axiomatic A equals B, B equals C, therefore A equals C. Realistically, the world doesn't work like that. It's all on probabilities. So I really like this slide by Palmer. So if you look here, intervertebral disc as their source of pain, which he used controlled discography with pressure manometry to determine who has discogenic pain, you can kind of see, interestingly enough, discogenic pain affects primarily young people in their most productive years. And as you get older, though the disc starts to degenerate and have tears and breaks in it, it's not really painful. It forms a less probability. If you look at facet joint pain, it's sort of less common when you're young, because the disc is still supporting and doing all the aggravation. As you progress in your 50s, it starts to rise up and then, of course, plateaus. And we'll look at what else takes over at that point in time, but that's easy to imagine. SI pain, as we move on and wear down the shock absorber of the pelvis, again, as you rise into your 50s and 60s, it becomes more prevalent. Again, not as high as these other structures, but again, present. Lastly, what's also setting in as we get older, particularly if you plan on living into your 70s, 80s, and 90s, hello, spinal stenosis, right? The end-all, be-all of living longer, right? Spinal insufficiency is the way I look at it. You outlived what you were intended to do, right? For the past 10,000 years, people never made it this long. And of course, we messed it up. Anyway, so the structure here, this is just a quick netter diagram to remind us that the disc is here. As this wears down, the posterior elements of the facet joint are interconnected through the bridge of the pedicle. So the facet joint in the back is a source of pain as this wears down from the front. So when we kind of saw that in the Palmer diagram that I showed you earlier. Looking at the disc. Now the disc, the quality of collagen is kind of what you're set with, right? So if you're set with good, strong collagen, good lamellar rings, and you have a nice, strong annulus fibrosus, well, you're lucky. And this is the main structure that a lot of people complain about as this wears down. And the nucleus pulposus is the center shock absorber. This is filled with proteoglycans that, again, hold on to a lot of water content. So if you look at young kids, they got a bright T2 signal because T2 lights up on MRI, nice buoyancy, water content in that when you're born, and good, strong lamellar collagen. As you decide to go down the degenerative cascade, there starts to form tears and breaks in the annulus fibrosus. The outer 1/3 of this is innervated. Pretty soon, this is when you start to get back attacks when you're young. Now, this final diagram from Bogduk et al. Is that you feed the bone, kind of feeds, the end plate feeds the cartilage, the end plate, and it also feeds the nucleus pulposus and annulus fibrosus. They get it by diffusion. So there's not a lot of perfusion to these structures. They're very avascular. They don't heal well at all. Pretty much. So in the 70s, we started to try to get a grip on all of these back pain problems. And what was sort of recognized in cadaveric models and kind of putting this disc degenerative cascade, which is reasonable even today as the disc develops tears. There's some hypomobility and synovitis or inflammation of facet joints that may show up. The disc tears further radially, that is going through the disc, and it makes it more vulnerable then to disc herniation. Same thing, the facets in the back start to get capsular laxity. Ultimately, the two structures, as they kind of get more compromised, they may cause lateral nerve entrapment in the lateral recess. That'll be looked at the MRI lecture. And then finally, you end up with spinal stenosis. Now, as far as disc degeneration, we throw that out, disc degenerative disease. It's a term used very commonly. And, the accepted definition is elusive because it just depends who you are. If we could look at the biochemistry of the disc, it is something where there's alterations, and I have that further down, between synthesis and degradation, where degradation starts to take over. As degradation starts to take over chemically, you start going in the wrong direction. You have less proteoglycans. You start to break down collagen. The disc loses its strength. It'll start to bulge out. It'll also start to make inflammatory mediators, and we'll look at that slide very carefully when I get to it. Finally, if you're a radiologist, you see just a darkening of the disc. It'll start to, as they say, desiccate. It'll start to cause diffuse disc bulging. We'll look at that a little bit, and that'll also be clarified in the MRI lecture. And so you get this more hypermobility. Metalloproteases are expressed within the disc. These are expressed by the chondrocyte cells within the disc, and they start to break things down, and we'll look at some of those a little more carefully as we move along. One argument that's been in the past argued is that the end plate develops deficiency. There's herniation of some of the nuclear material into it, so-called Schmorl's nose, but these can be entirely asymptomatic as well. I just put it up there as a thought, and you can clearly see how then, as this herniates through, there's more compression of the annulus fibrosus in the back. However, the actual insults are a little more elusive, and we just have associations that I'll go into in another slide. So you can see how then the annulus fibrosus gets compromised, kind of bulges backwards here at L4-5. And disc herniations are, by and large, when I see them in the clinic, which are a lot of these people that are just, as we call them, complainers, the disc is simply broken into 4 quadrants. less common is this focal protrusion. Usually what I see a lot more commonly is kind of a broad base or diffuse disc bulge where all quadrants have a little bit of bulging back with an annular tear, and often young people in their 20s, 30s, and 40s complain of back pain and intermittent radiating pain, but there's no neural compression. Here's an example of that desiccation or drying of the disc initially. Bright, nice T2 signals with good proteoglycan, good synthesis. Synthesis now is moving more towards degradation in this poor person. That then may then be accompanied by an annular tear, and that's this high intensity zone. The brightness of this rivals that of the T2 signal within the CSF, and this is called an annular tear, which may or may not be symptomatic. It is much more symptomatic the younger you are, especially if it's accompanied with loss of T2 signal as well as contour disc having a diffuse disc bulge. And here it is, kind of like what I'd usually get. Here's an older skin, because I'd usually read the MRI report as usual. This is usually defined as a diffuse disc bulge, little flattening of the thecal sac, small tear here, no compromise of the nerve roots. This person should be happy, should just go home and leave us alone, right? But of course they're not. They're complaining frequently of severe axial back pain, intermittent radiator leg pain, and it's not compressive, and we're stuck with the medical school model, which doesn't really work because so many patients come in, they all can't be lying all the time, right? So there's got to be other mechanisms that are triggering back and leg pain in these patients over time. And it took us a while. As this degenerative cascade goes on, you then get inflammatory setups within the bones. And this is the so-called, as the disc degenerates down, it can translate into the bone and cause vertebrogenic back pain. And there's been more therapies now targeting denervating this as another modality. The nerves to this typically come through the basivertebral vessels here with the basivertebral nerve that supplies this inflamed bone that further adds to the complexity of treating back pain in these patients, because now not just a disc doesn't have just a pain source, but it also is translated into the bones in some of these patients with so-called motor changes, and they'll get into that more into the next lecture. Looking at accuracy of MRIs. So the accuracy of MRIs in terms of predicting whether somebody has a back pain or not, we're sort of pitted against pressure-controlled discography by Connor O'Neill, who's the first author, and Richard Derby, who did some of this pioneering work in the early 2000s to mid-2000s. And what they pitted was if they found confirmed discogenic pain using pressure-controlled discography, which discography now has a little bit gone by the wayside, what was the MRI? What did the MRI really look like? And what were those parameters in particularly young folks, as I showed you with the Palmer study? It really correlated to moderate loss of disc height, loss of T2 signal, and a diffuse disc bulge contour. And these were your best independent predictors: nuclear signal, disc bulge here. It gave us a sensitivity of almost 80% and a specificity about 80%. So it's much more useful in younger folks where you have single morphology. As we age and that person comes in and has multi-level disc degeneration and they're a lot older, I mean, the specificity of these MRIs goes down. But again, the disc is probably not their painful source. It's a lot more usually with stenosis. Looking at discography, this was a technique that was near and dear to me because I practiced it with pressure controlled, and it was if it's done correctly, it's very, very useful. Unfortunately, it's easy to sabotage and do this poorly. However, in the 1950s, it was the way to diagnose sciatica. You would pressurize a disc, replicate the pain down the leg, and you just inject some with a syringe. You didn't have any pressure control, so you exerted any arbitrary pressure. And so that's what led to a lot of the subjectivity and discontinuation of this technique. However, when it was standardized with pressure control, we clearly saw people with manometry. You could really diagnose the sensitivity of these discs. We're talking people who would tolerate 15 psi to 30 psi. If you look at the normal human disc, it can tolerate 80 to 100 psi's and you're completely asymptomatic. So in other words, I stick a needle in the disc, I pressurize that disc, and you're talking to me like we're just talking about the baseball game or something. If you're very sensitive, you jump off the table at 15 psi's. Just to give you an idea of how sensitive these discs get. Now, just to put it in reference, your car tires are usually psi's in the 30s. So it just gives you an idea of how tough this disc is in relation to your automobile. when it's normal. So this kind of discography, it was kind of a technique where you inject contrast into the disc, and here it's kind of torn through, and you can see how the goes out to the outer annulus. And we defined multiple tears as these disc degeneration progress, each broken down to a third here, and then a third out here, and then it goes all the way out to the rim of the disc. And then here, they're kind of torn multiple tears to the outer aspect of the disc. And here it's torn all the way through the epidural space. What we usually do when we saw these patients in clinic is they'd typically be grade 3, 4, and 5 tears. To really diagnose this, you need a post-CT after you inject contrast in the disc. However, it gave us an idea of how these discs fared over time and what their morphology looked like when they broke down. So even dating back to the 90s, what is this disc doing as it tears? Well, what we've identified, and this dates back to a nice little Netter drawing, is that within these tears, there's neovascularization as well as nerve ingrowth. And this is from the gray ramus communicans that communicates here with an arbitrary part of the nerve root that's always been elusive, but it also communicates with the sympathetic trunk, making innervation of the disc complicated and challenging to denervate. Then, of course, with these tears, if you load up too much pressure, it can, of course, herniate. And here it shows you the classic medical school model of nerve root compression. If you then assay the discs of people who have long-term low back pain and then herniate, and you compare those people who just got acute sciatica from lifting or refrigerating, there are chronic elevations in cytokines in these discs. That was the inflammatory mediators that the Netter diagram didn't know about in the 90s, compared to people who just freshly herniate. So people live with a chronic low-grade inflammation where chondrocytes express cytokines. And if you then further do an analysis of these tears, you'll find that they also have nerve growth factor expressions as well as new microvessels and nerves. Furthermore, if you then also assay these discs that are degenerating, you'll find elevated tumor necrosis factor, nerve growth factors, brain-derived growth factors compared to healthy. So this is kind of the take-home slide, and it's extremely busy. I don't expect you to know, all these mediators, but I'm going to summarize the present understanding of sort of the disc and why back pain is a pain in the butt for doctor and patient. There are mechanical loads, genetics. Well, if you get infection, it's a horrible beast. But anyway, we'll leave that one out. And smoking. They somehow tip the nucleus pulposus cell into a pro-inflammatory state. So it does a few things. It'll elaborate cytokines to draw in macrophages, which will further amplify inflammatory responses. This will then activate the dorsal root ganglia, express sodium channels, express TRVP1 receptors, and we'll look at the DRG a little more carefully, and you'll get wonderful radicular pain. It'll also feed back and continue to augment the nucleus pulposus expression. So you're going down a pro-inflammatory pathway. This has been why we move towards steroids for treating back and leg pain, either injected or oral. At the same time, moving down here, there are expressions of metalloprotease enzymes that begin degradation of the disc in terms of collagen, in terms of the proteoglycans. You're moving towards disc degeneration, moving towards annular fibrosis tears, and you're moving towards herniation. So you're getting structural issues, inflammatory issues, and what's also lovely here is you're moving towards neuropathic issues. So just if I don't leave you with anything, disc-related pain has structural compromise, inflammatory compromise, neuropathic pain compromise, and all are moving targets over time. And this is going to focus a little more on neuropathic pain, which is just why back pain can become difficult when it chronicifies, is that chronification of pain through tumor necrosis factor expressing sodium channels to increase the firing or reduce threshold, so the DRG fires more regularly, you get wonderful sciatic leg pain. These brain-derived growth factors move into the spinal cord, you activate microglia, you destabilize the normally inhibitory surround of the lamina 2 and wide dynamic range neurons that you heard about through Dr. Adet in lamina 5, and you get wonderful spontaneous pain that's so difficult to control. Not everybody's radiculopathy is the same as everybody else's, right? Some people respond, some people do not respond to certain treatments, so on and so forth. Let me just skip that slide. Needless to say, it's very difficult to denervate. The rat models show us that basically these discs are innervated through sinovertebral nerves that then go into the gray ray myocommunicants that feed into the sympathetic trunk that then go through L1, L2, DRG. In humans, sometimes that accounts for why you get groin referrals with these things. And at the same time, this has a plexus here that feeds into multi-levels of DRGs through an anterior plexus of nerves. So it's not an easy beast to denervate. And it gets a lot of innervation, so you get continuous barragement of the spinal cord and of the dorsal root ganglia over time through these painful inflamed discs. So this kind of summarizes a little bit of what you're dealing with clinically. You got a beast that's inflamed, you got a beast that's falling apart. You get some hypermobility, you got psychological factors feeding into this, you've got new nerve ingrowth into the disc, you've got feedback to the spinal cord, overall very hard to deal with over time. So what happens to these folks? This is a good study out of China where they use pressure-controlled discography to identify those patients that have discogenic pain and followed them over 4 years to see what these people do over half a decade. But the important take-home point is close to about 70% of these patients just seem to stay the same. I followed my wife's sister-in-law with a wonderful annular tear at L4-5 for the past 20 years, and she's just the same. She has a hard time sitting down for a long period of time. Standing up is a lot better. Walking's a lot better. Being active is a lot better. But, you know, it's usually sitting that gets these people a lot. And majority of them tend to just stay the same. Now, moving into the beast I alluded to earlier is the facet. As we move along and degenerate the disc, here's a schematic from Dr. Warfield's book on disc degeneration here. As this degenerates, these facets get more strained. You typically have fixed axial patterns, less commonly to have radiation down the leg because they're a synovial joint. However, if they do entrap the nerve a little laterally here in the lateral recess is that vulnerable point in our spinal column, and therefore it is the one that frequently will cause additional sciatic leg pain. Facets are mobile, they move with the disc, and just like the disc, the lower levels are most commonly affected. And this is the two ways to think about facets in creating misery. The joint themselves can become painful, or the capsule can also elaborate inflammatory mediators, activate the nerve root here, or as they become larger as you disc degenerate, so-called facet hypertrophy, they can start to crowd back here, the recess right next to the thecal sac, and give you some wonderful stenotic symptoms as you get older, and you kind of walk 50 feet and you got to sit this one out. So here is the facet joint. So the facet joint was always questioned, is it a source of low back pain? Of course, we identified nociceptors, we identified substance P within the cartilage, as well as subchondral bone. And so we feel that this structure has substance Ps and CGRPs that are necessary, as well as prostaglandins to cause pain. So this is kind of a biopsy showing elevated IL-1 beta. IL-1 beta is one of these pro-inflammatory cytokines. If you compare the spinal stenosis group as just an older group compared to the disc herniation group when they were biopsied during surgery, the people who are older who are likely going to have facet disease will light up more than those who do not, and that's usually in the synovium. Facet joints also can grow cysts off of them as they degenerate and impinge the lateral recess. That is another way they can be sharp and obviously crowd that lateral recess, and you can see that there. Pretty easy to initially treat. Intra-articular facet joints have been around for years. They are effective in buying people months of relief, sometimes prolonged, but usually about several months. Other ways that people approach it is to target the facet joint nerves. The nerve above and at the level of the joint are usually targeted. They're very easy to see in fluoroscopy as shown to the right, and these nerves can be ablated by radio frequency, and I'll save that for the other talk. Looking at these joints, another indirect way is if you do bone scintigraphy of these with technetium labeled bisphosphonates, and you can see because of increased osteoclastic activity, these joints can light up in people with back pain. And if you treat those patients with intra-articular injections, you have a better chance. So group A, for instance, here had a positive scan, group A2 has a negative, and you can just see that the group A tends to do better for several months when you inject them compared to a negative scan. inconsistency with this structure causing pain. For the sake of time, we'll move into stenosis. And stenosis is a complex beast. You're attacked by a variety of structures as you degenerate. The disc moves back, the facet joints enlarge, the ligamentum flavum, about a third of patients, thickens up, and it starts to crowd the thecal sac. As there's crowding, there's exerted pressure where inflammatory mediators can accumulate, where ectopic foci of nerves can accumulate, particularly as you try to walk, where you increase the demand on these nerves for metabolic activity, and was alluded to yesterday. If we look and measure the pressure in these people's spine by putting an epidural catheter in various positions, patients with stenosis, they love to sleep. You know, you're 85 years old, you'll just sleep just fine. It won't really bother you. Of course, if you get into some yoga positions, you won't really like that too much. Your pressure skyrockets pretty quickly. A lot of old folks like to sit around. It relieves the pain, reduces the epidural pressure. Many of you stand upright, though, and extend that back. See that pressure rise up, 120 millimeters of mercury. You won't be going very far. So what do people do? Well, you get your walker, you lean over, and you dramatically reduce epidural pressure. And that's why we start off on all fours, you end up on all fours. You decrease the pressure in the spine and create space, which is kind of what you need. Because what will happen is that epidural blood vessels, once you exceed pressures of 30 millimeters of mercury, you'll start to kink these off. You'll activate the DRGs. It'll start to send down ectopic foci. You'll also affect the motor nerves. Your legs become like cement and don't listen to you. So that's kind of the nature of losing space. Finally, let's go back to the 1920s and we'll wrap it up. In the 1920s, great time to be alive, roaring 20s, a lot of parties, easy to be a doc, everybody's got SI pain. And you just do your provocational maneuvers is usually your first suspicion. There's no centralization of pain. In other words, you don't have central spine pain. It's usually off to the side. There's some type of either usually traumatic event or lift twist that triggers this whole thing. And today, even today, it's mostly confirmed with the diagnosis by injecting it with a small amount of anesthetic. You must have normal films, both MRIs usually and plain films. And the reason that's the case is because it tends to be much more what we call an injury to these ligaments that hold it together, including the sacrospinous, sacrotuberous, and the interossei ligament complex that holds this joint together. And remember, this is a shock absorber of the spine, both from above and below. So the pelvis really takes a hit when we're doing stuff over time. So these ligaments can become quite painful. It's not readily diagnosed by MRI. That's much more useful when you have actually inflammation or infection of the joint, such as a spondyloarthropathy, for instance. So usually those are negative. How do we get this? Well, usually you can get fused, you can degenerate over time. If you have abnormal vectors, for instance, with scoliosis, your spine is tilted preferably to one side, and it may cause wear and tear over time of that side. Again, about 15% of back pain. Typically, the pain is up here, just an isolated spot, less commonly for it to radiate down the leg. Heavy innervation by the posterior rami here, not the whole story, but you can see out of the S1, S2, there's innervation of this joint. And it's pretty miserable pain. It can be pretty life-limiting. Usually not to the degree of disc herniation, but it can be pretty life-limiting, having had that one, unfortunately, myself. And the ventral capsule is also innervated, but it doesn't seem to be as important as the posterior. So just going back a little bit into diagnosis, there's no valid single test, I got this and I have SI pain, because it's usually the ligaments that are involved. You usually do at least a couple of three diagnostic physical exam maneuvers that help you suspect it. I listed a few on there for the slide for you that are most commonly used, that were gone over during the back pain talk. Some of these studies suggest sensitivity and specificity that are high, but you must, for the most part, they shouldn't have pain over the sacrum or directly in the lumbar spine to get these numbers. Accuracy of diagnostic testing. Most testing should be negative and won't lead to the diagnosis. Intra-articular injection with low amounts of low volume anesthetic with complete alleviation of pain. on following 2 diagnostic injections, because the first one you get a lot of false positives, right? Patient meets me, they like me all of a sudden, they feel suddenly better. I think we need to repeat it a couple of times. Even then, I still think we have significant false positive rates. Keep the volume low so you don't anesthetize everything. Diagnostic criteria, I shoot more that you must have all the pain relieved. Some go down as low as 50% pain relief for the diagnosis, but I typically dwell much higher. In other words, the pain should be reasonably numbed away. And most success, like anything else, like facet joints, about 1 to 3 months of relief. So try to catch us up a little bit of time. Low back pain is always a moving target, kind of like cancer pain. These patients are always on the move with degeneration. They love to degenerate their spine and find new structures for you to treat. And that's just a continuing target, because you know, probably other doctors looking at us saying, there he goes again, injecting that patient's pain. They're back again, or giving them medication or sending PT. They're always on the degenerative cascade. Lifestyle modification, most of these patients, that's what they've had to do, change careers or stop doing what was exacerbating the pain initially, which is usually some heavy lifting. Remember that now we're going a little back more to the psychosocial model of pain. I'm leaving out the biological, that psychosocial factors significantly influence pain. I always tell patients who say, well, how come it's not in my head? I go, just pretend right now. You get your back pain, what is it they'll go, 8 or a 9, whatever silly number they give it. I go, how about I just give you $1 million right now? How bad's your back pain? Oh, not so bad, huh? And then I'm like, see, that's the psychological and social component of pain. I just fixed your pain. Didn't even lay a hand on you. So it is very, very important that psychological factors feed into this whole thing. It can be clinically difficult to distinguish all these structures, and these structures evolve over time, and they're interconnected. And at any point in time, you know, the only way sometimes we arrive at whether it's more inflammatory, mechanical, and neuropathic, unfortunately, are through treating. If we give a steroid shot or oral steroids and all the pain goes away, well, pretty inflammatory. If you do that and there's a good-sized disc and they got nothing out of it, it's probably mechanical, right? Big disc occupying space. Finally, you give a steroid shot, all the mechanics are good, they've had back surgery, the steroids don't touch them, medications don't touch them, the mechanics look good, but you still have back and radiating leg pain. Fortunately, you're in the neuropathic gang, and that's chronic pain. That's where neuromodulation comes into play. But anyway, and all these targets can blend and reblend over time. Thank you very much.